Over to Dr. Sami.
Thank you very much, Dada. Thank you to Microlab, Shrish in particular. These are the contents of the details. I'll just rush through them. Otherwise, I know that we are a little behind time. So global case fatalities rates attributed to coronary artery disease have been plus 10% regardless of where they are. Recent case reports of COVID patients, 16.7% developed arrhythmias, 7.2% experience acute cardiac injury, apart from other COVID-related complications. No reports on prevalence of cardiac complications in CAD-A versus cardiac comorbidities, and autopsies of COVID patients revealed infiltration of myocardium by interstitial mononuclear inflammatory cells. That means there is a lot of involvement of the inflammatory processes in the myocardium. It is associated with the increase of cardiac biomarkers, as is very evident in case there is any myocardial damage. The myocardial biomarkers obviously would have gone up, which they did. So in a study by Shai et al. Involving 416 patients, cardiac injury was a common finding in 19.7%, not necessarily myocardial infarction, so to say, like the way we understand to be type 1 myocardial infarction. And coronary artery disease, heart failure, and cardiovascular disease, cerebrovascular disease were 10.6%, 4.1%, and 5.3% respectively. So this is how it complicates the cardiovascular system. Whenever there is an infiltration with the COVID, there is a direct viral invasion. And second is post-viral invasion, there is a cytokine storm. All of us understand that. What happens with viral invasion is that there is one element which is directly hurtful to the myocardium, and there is yet another component which is hurtful to the arteries. But by and large, what both of them do is, whether it is direct involvement of the myocardium or whether it is via the coronary arteries, that vascular inflammation occurs, that there is a myocardial injury which can eventually lead to arrhythmias and myocardial infarction and heart failure, cardiogenic shock, and eventually death. When it comes to cytokine storm, then it is basically the inflammatory process which is leading to plaque ruptures, instability of the plaque, again ending up with myocardial injury or myocardial infarction. There is yet another pathway which the cytokine storm can take and does take more often than not, is procoagulant state. This procoagulant state leads to thrombosis, including pulmonary embolism, and that's the reason why this debate has started on the WhatsApp, that whether it is bacteria or whether it is thrombus alone. But now, whatever little we understand of this disease process, there is a lot of thrombosis, and that is how it gets picked up in as a pneumonia or a pulmonary artery embolus in the CT scan, and that's the reason why it is called. CT scanners have a better pickup rate than the RT-PCR. Sympathetic overactivation is a combination of infection, inflammation, whatever, but what it does is that it alters the myocardial demand supply, and it leads to that mismatch, leading to heart failure, cardiogenic shock. There is yet another third process which cytokine storm happens, which is the respiratory distress syndrome, whether it is because of immunological issues, whether it is because of inflammatory issues, that we are not going into the discussion, but certainly it leads to hypoxia, which can lead to, again, excessive thrombosis and pulmonary embolism, or myocardial supply demand mismatch. So the mechanisms, I'll just summarize in this slide that there are mechanisms of cardiac injury is that there is a direct toxicity through the viral invasion of cardiac myocytes, that is myocarditis. Then there is ACE2 receptor mediated cardiovascular injury, which is hurtful to the cardiac muscle and the endothelium both. Microvascular dysfunction and thrombosis, cytokine release storm, mainly IL-6, which is inflammatory marker, stress cardiomyopathy, and it manifests something like the conventional Takatsubos that we understand, and this can lead to imbalance of myocardial supply and demand. Cytokine storm, many severe COVID-19 reactions can be traced to severe immunological reactions known as cytokine release syndrome or cytokine storm. The rapid release can be catastrophic, leading to multiple organ failure, Many severe cases of COVID-19 with multitude of complications are directly related to cytokine storm. Cytokine storm in ICU patients causes tachycardia, tachypnea, diaphoresis, and elevated D-dimers. Now, depending upon which way they are going, then the choice of medication will come. If the D-dimers are high, you would expectedly put the patient on anticoagulants, whether it is the heparin types or low molecular weight heparin, or whether it is the newer oral anticoagulants. Those choices keep on changing depending upon which is the parameter which is predominantly worse off. Though several times all of them would be worse. Many patients progress to renal failure with about 30% requiring renal replacement therapy. Now, there is yet another issue, and that is that of venous thromboembolism. Now, respiratory failure in COVID-19 is driven by both acute respiratory distress syndrome and microvascular thrombotic processes. And there is a strong association of D-dimer levels, disease progression, and chest CT features suggestive of venous thromboembolism. Various studies have demonstrated a very strong association between the D-dimer levels and severity of disease or poor prognosis. Here are an examples of a 68-year-old man. If you keep looking at these arrows here, you will find that there is basically acute pulmonary embolism with pneumonias, which can be detected by CT scanners, and that's the reason why one of the major investigative imaging tool is currently. You can see it here that branches of the pulmonary artery are getting involved in several places. That's basal pneumonias. So these are all things which can be picked up by CT scanner. Unfortunately, we are in an era where CT scan, at least in the urban population, is very freely available. Now, as recently as June 1st, the US FDA has issued an emergency use authorization allowing the Biomed Impala. Impala is a catheter-based heart pump, which is a very small pump which you can insert percutaneously, and this is actually basically to buy time and stabilize the patient, though it is only a temporary thing, or not even semi-permanent, but it is temporary implantation, which all of us used to use very extensively in high-risk angioplasties and high-risk procedures on the left side, but this time it is for the first time for the right side that they have allowed this pump to be used in patients with pulmonary embolism and right heart failure. So what it does is it picks up the blood and distally it ejects out through a pigtail catheter, and so the at least perfusion into the kidney continues. Now, these are certain drugs with associated complications. Every now and then the drug would erupt, and then they would find the reasons not to give it. And the first few was the chloroquine derivatives, hydroxychloroquine, chloroquine, and azithromycin, though that is a macrolide antibiotic, but they can all cause throat interval prolongation. So one of the reasons we prefer not to give it in cardiac patients, especially with throat prolongation of these. So the several cardiological societies and FDA warned against the use of these drugs as they can cause venous complications and possible death. Bradycardia was more common in critically ill COVID patients who received the combination of antiretroviral medications, lopinavir and ritonavir. These are basically used for HIV and AIDS, and their protease inhibitors. They have their own issues because drug-drug interaction with lopinavir and ritonavir are enormous. So the risk of bradycardia was more common in elderly, especially beyond the age of 62 years. And it could be a sign of severe cardiological and neurological impairment since it is associated with lymphopenia. When it comes to stroke, whether it is ischemic or hemorrhagic stroke, a study which was from Italy showed that 15% had acute neurological symptoms requiring neuroimaging, and the most common neurological symptoms were altered mental status, which was in 59%, and ischemic strokes, which were close to about 31%. So ischemic strokes were higher than the hemorrhagic strokes. Both ischemic and hemorrhagic stroke are associated with COVID infection, as is true with any infection. So let me just clarify one thing to all of us, including that COVID is most special when it comes to complications. It is special because of its infectivity, it is because of severity, it can kill a lot of patients, but when it comes to complications like all viral infections or like any bacterial infections, the complications can exist, though the percentage may be varying somewhere. So both ischemic and hemorrhagic stroke are associated with COVID infection and carry a high risk mortality. ACE2 receptor circulating cytokines and hypercoagulability are integral in the pathogenesis of stroke in COVID-19 patients. Treating physicians should have a low threshold for suspected stroke in COVID-19 patients. Close observation should be kept in such patients, particularly those with clinical evidence of traditional risk markers. So this is a very busy slide, but the sum and substance is that first is that during and post-COVID pandemic, you should have the awareness about how to do. Then there is avoidance, and then there is action, which right from the lockdown till what Amitabh Bachchan has started saying is all that has to be done. And assume as a physician that everybody is COVID positive, even in absence of typical symptoms. Once having said that, then you can continue to minimize the number of providers encountering any patient, avoid close contacts if possible, personal protective equipment whenever necessary should be given. There is consult for admission with suspected or confirmed. So all suspected patients should be taken as confirmed COVID until unless proved otherwise. If there is any ambiguity, just continue to maintain precautions like the way you would do it for absolutely positive COVID patients. Now, these are certain broad guidelines that in case there is somebody who is suspected or this thing, preferably at virtual visits, preferably don't have personal encounters unless it is absolutely necessary. And if it is absolutely necessary, then all of us who are looking after the patient should be in PPs, which includes N95 masks, gloves, gowns, eye protection with appropriate techniques of donning and doffing to be taught, avoid close contacts, and N95 recycling as per institutional policy, though that is not a thing which is easy to do. Now, for confirmed cases, and follow-up should be there in about a couple of weeks, and if in-person visit is needed, then delay it for about 4 to 6 weeks, and inform clinic staff in advance if it is in less than 4 to 6 weeks so that they can take adequate precautions. Biomarkers, the increased cardiomyocyte injury quantified by troponins, whether T or I. Advantage of I is a little better for patients with CKD, and rest is all hardly difference between T or I. So cardiomyocyte injury quantified by cardiac troponin concentration and hemodynamic stress, and quantified by B-type natriuretic peptide or NT-probe BNP concentration for disease severity and mortality. D-dimers quantify activated coagulation and is a prominent feature in COVID-19. Mildly elevated cardiac probes or BNPs are in general the result of pre-existing cardiac disease and or acute stress injury related to COVID-19. Though measuring cardiac troponins is needed only if the diagnosis of type 1 myocardial infarction is being considered in patients with COVID-19. And just to revise, type 1 myocardial infarction, that is conventionally, very conventional because of the atherosclerotic lesions underlying. Now coming to the diagnostic recommendations for patients without any significant cardiovascular symptom and low-level troponins. In the absence of hemodynamic instability, LV function is not recommended. Close contact, so whether it is ultrasound or whether it is echocardiography, unless absolutely indicated, you should try to avoid it. And if at all you need to do it with the proper PPE. And of course, you have to take care of the machine also. So your machine has to be also sheathed and well covered with transparent sheet. which needs to be sanitized the moment that machine is out from that COVID area. Like the way you on and off yourself, similarly the machine has to be on and off, or you leave it there in the COVID area. So for patients with hemodynamic or electrical instability more than mild troponin elevation or heart failure, further cardiovascular testing, including bedside echo or focus, should be considered like the way I have told. And if the patient with suspected or confirmed COVID has any specific cardiovascular symptom, ECG abnormality, arrhythmia, heart block, and elevated drops, then coronary artery disease or myocarditis should be suspected. So this is a broad algorithm for triaging patients with suspected acute cardiovascular disease. So there is an ER axis. Check the list of probability of COVID infection, and the probability of COVID infection is if the fever is more than 37.5, respiratory symptoms, previous contact with COVID patient, or there is a family history of COVID infection. If there is no COVID, then you have to follow the standard protocol. If there is a COVID infection which is positive, then look whether there is a cardiovascular condition needing hospitalization. It totally depends upon vital signs of stability, and till such time it is considered or proven, then they have to be in a suspected area. Or if the unstable condition is there, then first care and then screen in the emergency department. So you have to be very cautious in case there is anything instability. You don't leave the patient unattended, but you keep yourself protected. Number two is that if there is a cardiovascular condition not requiring hospitalization, then you discharge, sent home for quarantine, considered for outpatient management. There is consideration for patients with suspected cardiogenic shock and COVID infection. This is a little bit of a tricky situation where you have to be always on the guards, you have to wear PPE, and if shock is confirmed, then treat as proper monitoring for differential diagnosis with or without sepsis. However, if it is not, then confirm COVID diagnosis first, and then you take care of things very aggressively. And whenever there is a risk of or suspicion of cardiogenic shock, then myocarditis should be always a possibility, because one of the recent studies which has been taken off showed that almost 78% people had some kind of, this is data from Germany, which for some reason had to be taken off because of whatever overreading and suspicion, and not to cause panic. So not only that, you must consider sepsis also as a possibility of having etiology. Now, this is the algorithm of managing cardiogenic shock in patients with suspected or confirmed. So first is you have to have troponins done, BNP done. If there is a possibility, then you can do a superior vena cava oxygen, central oxygen saturation, so that if it is less than 60, or mixed oxygen saturation from pulmonary veins, which is again 35 millimeters or lesser, depressed LV or RV functions, rule out acute coronary artery syndrome, then consider PA. Whenever you are doing a PA catheterization or intubation, you have to be in proper PPEs with a shield and double mask or whatever is the protocol you are having in your own hospital. Then the bias is that even in a cardiogenic shock, the conservative management is preferred. And you consider this mechanical circulatory support only when the patient is refractory to medical therapy. And then if it improves, then you continue without mechanical circulatory support. But try to see to it that there are certain relative contraindication even when there is an established need for mechanical circulatory failure. If there is somebody who's greater than 65 years of failure, BMI greater than 45, advanced comorbid patients at baseline that limits life expectancy, and inability to tolerate anticoagulation. These are certain relative contraindications, though not absolute, because there is no absolute contraindication for mechanical circulatory support. In any case, you're losing the patient. In case there is somebody who's got a respiratory failure with refractory hypercapnia or hypoxemia despite ARDS treatment, then you have to start looking at other options. And these options are whether you want to put the patient on ECMO or you want to put the patient on mechanical circulatory support with ECMO or not without ECMO. But those are tricky issues which get sorted out on a case-to-case basis. You can have, if there is a left-sided isolated failure with right ventricle being normal, you can consider VA. If there is both, then you have to consider biventricular ECMOs or a staged mechanical circulatory support. Those are things which will be depending upon what the case situation is. Now coming to possible etiologies for pollen elevation in suspected or confirmed COVID, and these are algorithm for that. That for cardiovascular symptoms, troponin elevation patient with suspected or confirmed, this thing is have an ECG, monitor the patient by telemetry. Trends of troponin should be there, and consider focus. Focus is point of care ultrasound, which person there should be reasonably able to do. Otherwise, not. You can take the images and send the patients online, and you can experts can comment on that. Or
Dr. Samir, would you please summarize now?
Okay, so these are certain things where you have to consider myocardial injury, cardiomyopathy, type 2 myocardial infarction, and acute coronary syndrome. And I'm not going to just quickly highlighting there are certain drugs which have to be carefully looked after. Actually, if you have to give in acute coronary syndrome, then because of the increased bleeding risk, prasugrel is recommended if you have to use lopinavir and ritonavir. Apixaban is not recommended unless there is an absolute need for it. Don't use GP2B3 inhibitors. Okay, so quickly going to, in case of fibrinolytics, then tenecteplase is the reasonable choice. When it comes to mineralocorticoids, spironolactone is preferred, not eplerenone. You have to be very careful when you are using digoxin. Preferably, I don't use them. QT interval is a big debate these days because Torsed is an issue with QT interval prolongation. And if in case you are looking after the electrolytes, try to maintain magnesium more than 2 and potassium more than 4. And when it comes to thromboembolic phenomena in COVID, then venous thromboembolism has been reported in high percentages, and one of the systemic reviews reported occurrence of VT as 20%, while cumulative incidence could rise almost about 50% for hospitalized patients. CT is the investigation of choice, and then you have to manage them with unfractionated heparin or low molecular weight heparin. There are actually no specific proven treatment for COVID-19 associated myocardial injury, and current therapy is based on reducing viral replication and modulation of the post-inflammatory response. And one of the reasons why steroids have taken a high-dose steroids have taken over in a big way is for those issues. Avoid NSAIDs. Combination of HCQS and azithromycin is a bad combination to be used. Younger patients and those requiring non-invasive ventilation may benefit from remdesivir. And actually, FDA has also issued some emergency use authorization. We are using it quite often, more often than probably what is the recommendation. But some people have found good results with that. Such medications may be considered after consultation with infection disease patients. Steroids are typically avoided. It may lead to hemodynamic instability and end organ damage. But the use of steroids have been efficacious in treating myocarditis from immune checkpoint inhibitors on giant cell. IVIG, HCQ, avoid HCQs, ACE inhibitors and ARBs went into some kind of a very strong debates, but most of the societies have said that they're reasonably safe. Statins usage has brought down the severity of the disease compared to 27% people who got admitted were on statins and they had beneficial. They had lesser of complications and they were lesser into the group of severe. ECMO and other hemodynamic support are case-to-case basis, but FDA has cleared ECMO therapy for longer than 6 hours of COVID patients in shock. And that is the reason, and abiomed, which is the mechanical circulatory support, can be used. So it is not clear if hypertension is age dependent, but it is essential that hypertension remains well controlled. Do not stop ACE inhibitors of ARBs, and may plaque instability and MI, which is a common cause of death, is to be sorted out. So concluding that cardiovascular complications are a common finding, pharmacotherapy an integral component, drug interactions have to be very carefully seen, and hydroxychloroquine and protease inhibitors deserve special note because of drug-drug interaction. And there I will end saying sorry, I just crossed a few minutes over. I understand we are running out of time, but I'll stop here. Thank you very much, Dr. Sumitra Kumar.